As we await this hearing on health care coverage to get underway, an item that we'd like to let you know about, Senator Patrick Leahy, who is the chair of the Senate Judiciary Committee, is expected to comment on the nomination of Michael Mukasey, President's nominee to be Attorney General of the U.S. He'll hold a news conference this afternoon in Burlington, Vermont. He's scheduled a committee vote for Tuesday at 10 a.m. Eastern. C-SPAN 3 is expected to cover that.
We are a nonprofit, nonpartisan think tank, you may know, that is dedicated to actually creating space for a bipartisan conversation. That means on a normal day, my job is to remember that sometimes in this town, Republicans believe things that are not true and Democrats want things that cannot be, and my job is to piss them both off every day, but to keep them talking to each other, because in fact, if we don't have a bipartisan conversation, we're not going to get very far in health policy matters. In my opinion, we do have a bipartisan S-chip bill. 18 senators voted for it the first time, 44 in the House. Republicans voted for it. And we had just not quite enough to override a veto. The White House doesn't like that kind of bipartisan, but that bipartisan is, I submit to you, the future, and eventually our country will come around to that point of view. Well, today we have, I think it's fair to say, the job of think tanks is to throw ideas out there, and ideas that are somewhat new and somewhat unusual, and we certainly have that today. I can't tell you how proud I am to have had the help to put this thing together. And let me first call out my colleague Elizabeth Carpenter over there by the door, who very much carried the ball and made this happen. She's part of a very able staff we have. My guy's been floating around. I'm sure you've seen him. But basically, the excitement today is generated by Marge Ginsburg, who comes to us all the way from California, fresh from the California wars. But Marge runs a group called Sacramento Healthcare Decisions, which essentially takes in as its mission to try to teach people how to think about trade-offs in lots of different ways. And what's beautiful about it is it builds upon a lot of work that came out of real science, out of real psychology. We have, in fact, one of the inventors in the back of the room, if you would stand and take credit from NIH, who basically designed a way to think about trade-offs and how to teach trade-offs to people. You know, in economics grad school, we're taught trade-offs are what you're supposed to focus on, and only economists understand it. Well, it turns out, A, we're not the only people who understand trade-offs, but B, if the people don't understand the trade-offs, what is the point of being told by an elite? So what's great about this work that NIH invented, that Marge has taken to a practical application, is that it actually teaches real people how to think about choices that you need to make when you're selecting the elements of a benefits package. Now, some might say, if we can't agree on S-chip, why are we talking about a benefits package already, thinking about reform, thinking about what might be required? Well, A, in Massachusetts it already exists, and we're going to hear later from CELIA WCISLO, who is an officer of 1199 SEIU in Massachusetts, and perhaps even more importantly for this morning, a member of the Connector Board, which is the group, the publicly appointed body that actually makes decisions on behalf of the people. And I think it's fair to say Celia will tell you about how that public input process worked. And then we're going to hear from CORI UCCELLO from the American Academy of Actuaries, who is their senior public fellow. Her job is to explain actuarial speak to the United States. And so CORI is probably the only person in that profession who actually does speak English, and we're quite thrilled to have her here. I got to know her at Urban a few years ago, and I can vouch for her English-speaking capacity and her actuarial talent, so I'm looking forward to that. But back to Marge, I will just say that what she has done that is incredibly path-breaking is developed a way to present these complicated trade-offs about benefit package elements in such a way as to engender public participation and support. And what you have before you is a paper, and you'll hear from Marge in a moment. It's not going to tell you exactly what the benefit package should be. You know, that's what the traditional elites try to do. We're not about that at all. It's all about discerning what different groups of people actually want the benefits package to be. And the beautiful thing about Marge's experience is that she's done it for labor groups, for employer groups, those groups together, and most recently to the actual uninsured. Yes, they do exist, and Marge has talked to them, to the actual uninsured folks in California about the kinds of trade-offs they want to make. So let me get out of the way and let this incredible program come to you. Marge.
Welcome. Okay, I realize, and I apologize, the slides are a little faint, so where I would normally assume you could follow along in the slides, I'll give you a few cues just to make sure that you can actually follow what I'm talking about. We actually didn't create from the beginning in California the whole idea of what a basic benefits package should look like. In fact, it's quite interesting because in 2003, Blue Shield of California, as part of a really big initiative to try to bring universal health care to the state, decided that they actually ought to start by trying to define what is it that is critically essential to be in this basic benefits package, since they figured it probably might be a smaller benefits package than is typical. So they brought together a whole bunch of physicians in California, leaders in various disciplines. They met for like 5 days to create what was going to be the basic benefits package, looking at a whole bunch of different medical problems as well as treatments and the like. And their results, and this is their words, this is closer to a comprehensive package than to a minimum. And this is not to disparage in any way their results or the efforts they put into it, but basically to look at all the medical problems, all the ways of treating them, all the things that we pay for now and the things that we should pay for in the future, and then to decide which things are going to throw off the coverage lifeboat is simply counterintuitive to the average person and proved to be an impossible task. I would think, though they didn't make this conclusion, I do, that their problem in trying to define what is essential when everything's looking pretty good is that they, in fact, didn't start with some kind of parameters under which they had to function. There was no budget that they had to squeeze everything into, nor did they have something that they could then prioritize the health care needs that were important before they decided what stayed and what didn't. So starting from scratch and just looking at the whole world and saying what we need, what we don't, is probably not going to get you a basic benefits package. We know now that the average cost of insurance for a premium annually is about $4,200 a year, give or take a few hundred. And very few people believe that if we're going to have a coverage expansion program, that we can actually get there with that amount of money. And yet the topic that Lynn said that few have been talking about is then how should society allocate health care resources when we don't have enough to go around for everyone? Just a couple words about Sacramento healthcare decisions. For about the last 8 years, we've been focusing projects all having to do with finite resources. A number of those projects specifically have been about probing basic benefits. What's particularly important in understanding our work is that it's critical that what we ask people are things for which there are no easy answers. We have plenty of opportunities to ask the public the softball questions. What do you want from health care? People have no problem answering that. But when we ask them the question, what are you willing to give up? What do you think you can do without? What is more important than something else? That takes some very careful deliberation. And those are the kinds of approaches we pursue for people in order to find out, when all is said and done, what are those values that really drive the difficult trade-offs people might have to make. Before I launch into this, I do want to thank New America Foundation for both the opportunity to prepare the paper that's sitting out there, and also for the opportunity to present to you today. And I also want to acknowledge California Healthcare Foundation, which has been the primary funder for the projects we've been doing in the last 7 years dealing with finite resources. We really could not do it without them. Okay, so this morning I'm going to do 4 things. I'm going to suggest some of the strategies for controlling costs through benefits design. I'm going to illustrate a process then for how this might be applied in terms of bringing consumers into the discussion about trade-offs. I'm going to show you just a few of the differences in consumer priorities that we have learned, and then discuss briefly what the significance of public engagement is. I do want to say off the bat that, first of all, cost containment does not rest exclusively with how to create a smaller benefits package. We all know that there are other ways that are critically important for cost containment, reducing the prevalence of illness and disease, and trying to get a handle on how much we're actually paying to treat people who are ill. But even if both those areas are attacked with vengeance, and many policymakers have lots of good ideas on how they can get them, ultimately we are still going to have to look at benefits design. So doing one of the 3 does not preclude the other. So our task is, what are the priorities for coverage if our coverage expansion programs do not have the same amount of money available that I suspect all of you in the audience and that I have as part of our benefits package. Okay, so strategy number one that we look at in terms of cost containment is the most obvious one, which is cost sharing. That's the first step all health plans take when they're trying to figure out how are we going to spread the burden to others, is they say, we'll just put a larger burden on the individual, whether that's a higher proportion of the premium, co-payments, high deductible health plans, whatever. It's shifting the cost responsibility onto the individual. So as a strategy for defining what basic is, one of the key things is how do we find that right balance between what the individual should pay and what should be a responsibility of society. The second strategy is the provider network. And we know that many of you may be familiar with the work of John Wenberg and others at the Dartmouth Atlas, who've looked at this incredible variation in practice patterns throughout the country, in some areas where a tremendous amount of money is spent and a lot more things done to people with no better outcomes, and in some cases often worse outcomes. So in fact, if we have physicians who are inefficient, who aren't providing the same quality of care, should in fact we use the idea of provider network to get to high quality care at a lower cost. I didn't dream this up. In fact, many organizations are starting to do this. As you can see, even CalPERS plan cuts costs by cutting doctors. So even the big guys like CalPERS, the large purchasers, are starting to say, this doesn't make any sense. We have to figure out a way how to get most efficient provider network. Now this one, of course, is not an easy one. It sounds like it'd be logical. Who could be unhappy with high-quality doctors? But in fact, this deals with a real core value that most Americans have, and that's of choice, their ability to go to whichever doctor they want to go to. The third strategy is what we call treatment value, and it's how do we get our money's worth. And this has a lot to do with the concept of evidence-based medicine that we know, increasingly we know, that there's a lot of what we do in healthcare that isn't terribly effective, but we keep doing it anyway out of habit. And that many times there are things that we provide for patients that may have some impact, but are very costly. And the two examples I have up here, for those who can't read it, nominal benefit is seen in drugs for Alzheimer's from the New York Times 3 years ago. And yet Alzheimer's memory enhancement drugs are used to great extent throughout the country, and yet there's a great deal of doubt of whether that really is providing much value. Avastin, 100,000 equals 5 months of life. Many of you are following all of the new cancer drugs. There's some pretty dramatic things happening, but often the outcome, in this case, it costs $100,000 a year for an average gain of 5 extra months of life. Is this really the type of treatment value that will maximize how we spend our healthcare dollars? So that's sort of strategy number 3. How can we look at that? And the fourth one is prioritizing needs. And this one is almost as common as cost sharing in terms of what current health plans and purchasers are doing. They're basically saying, okay, we offer this whole array of healthcare services under a benefits package. Are there some that we can kind of lop off? And, you know, nobody will be too worse for wear. So some of the common things that get dropped might be durable medical equipment, even pharmacy benefits, mental or behavioral health services. So that's looking at these and saying, you know, are there some things, in fact, that really don't have to be part of a basic benefits package? But prioritizing needs also gets to a bigger issue that's starting to happen today. This article says, doctors plan womb implant. Addiction to video games should be a disorder, AMA said. That as we've expanded what we can do and what we know about medicine and how to treat things, so have we expanded our whole vision of what medically necessary care is and what should be covered by insurance. So prioritizing needs says maybe we should really develop sort of a bigger picture of what is healthcare all about and what is insurance intended to pay for. The project we've done called Just Coverage, which we did in 05 to 07, basically started with the premise, okay, in California, if we're going to have universal coverage or at least some sort of expanded program, what is the best use of our limited resources? We did 2 sets of discussion groups. Our first one was 71 meetings in Northern California with almost 800 folks who participated. Most of these folks were participating voluntarily, so not surprisingly, many of them were well-educated, insured, above-average income, you know, folks like you guys, who'd love to attend a meeting to do benefits design. We then did a second iteration of the project this spring in response to the interest of the governor and others in universal health care in California. We did 11 more meetings, but this time we did it statewide, and we did it only with people who had been uninsured for over a year and who were at 100 to 300% of the federal poverty level. This was the group that they were sort of looking would be partially subsidized but not entirely subsidized. Oops. We used, and to do this, and I'll explain in just a second, we used a computer process called CHAT, Choosing Health Plans Altogether. And this is the computer, the tool that we have been using since 2002 to address the issue of trade-offs. One important aspect we asked people to do when they were designing this package is we asked them to look at it in terms of their perspective as citizens, not their perspective of patients. So you can imagine for many people that was a whole new way of looking at benefits package. I'm going to briefly describe to you what the chat board looks like, just so that you get an idea of what some of the trade-offs people had to make, and then perhaps just a few of the responses I give you will make more sense. The chat board is basically a pie chart. It had 14 categories of services, and we divided them not so much in services as we decided to focus on health care needs. We thought maybe we need to relook about what we mean by health insurance and what the purpose of this is. And it isn't really about paying for services, it's about meeting health care needs. So that's how we created the chat board. We also had categories that dealt with the system itself, such as the provider category, and 2 cost-sharing aspects, co-payments and premium. Now you notice all these little wedges have a bunch of white dots on them. These are marker spaces, and this indicates the value, the cost each one will take in order for people to put it on their plan. There are 80 marker spaces altogether on this chat board, but people only have 50 markers to spend. So they have to decide exactly where they're going to put it and then how far in. Each category, if you look at, say, maintenance, has 3 tiers. So the higher the tier, the more markers it costs you, but the better the benefit. So they're not only having to decide which categories to include, they also had to decide some of the parameters of what coverage is actually going to look like. So we incorporated those 4 strategies: cost sharing, provider network, treatment value, and prioritizing needs, all within the chat board in both the categories and the tiers. When people were making this decision then, they really had to look at how they were going to compromise some of the core values that we know Americans hold about health care. Those values are affordability, choice of provider, access to the latest advances in medical science, you can't put a price on life, and that personal treatment options are decided by the patient and the doctor, not by health plan accountants and green eye shades or by the rigid formulas of cookbook medicine. So all this gets incorporated, and they get to decide how important these things are to them. Chat is done in 4 rounds. The first round, the whole group, which is about 12 to 15 people, each have their own computer, they work independently, and they design the plan that they think makes the most amount of sense. Round 2, we have people working together in groups of 3, and now they get to experience for the first time the challenge of coming up with a plan that the 3 people can all agree makes the most amount of sense, so they learn negotiation and trade-offs. The third round, which is really the key, is when the whole group works together, using a screen like this with a facilitator, and together tries to figure out what this basic coverage should look like. This is particularly important for the purpose of the project because for us, what we are learning is the why question. It's important to know what they pick, and CHAT, of course, captures all the data that goes into it. But most important, for our perspective, we want to know why. Why is it that vision is absolutely essential? Why is it that you're willing to compromise on the provider network? Because that is what we begin to understand then, how people think about what is critical in healthcare. The last round, they go back to their own computer and they decide all over again from their perspective. And of course, it's quite interesting to see how they've changed their mind between round 1 and round 4. To make things interesting, because it's one thing to tell people you can design it and this is what it looks like and this is the benefit, but unless you actually know how it's applied in real life, why should anybody think that what they picked wasn't the cat's meow? So we have something called the Health Event Lottery, which is done after rounds 1 and round 2. And what happens is each computer comes up with a lottery card selected at random on any of the 15 categories. And I'm going to give you an example to show the kinds of tensions people have to face. This is catastrophic. While trying out his son's skateboard, Joe crashed into a wall and knocked unconscious. Rushed to the hospital, he spent a week in the ICU that cost $100,000. Though his life was saved, he lost his eyesight in the accident. Your typical everyday catastrophic event. Okay, if you had picked Tier 1, his health plan paid the $100,000, but it will not pay for a $20,000 surgery that has only a 2% chance of recovering his eyesight. Now, if you had the foresight to spend one more marker for Tier 2, then this would have come up on your screen. His health plan paid the $100,000. It will also pay $20,000 for surgery, even though it only has a 2% chance of recovering his eyesight. So we're really asking people to make some pretty horrendous decisions. Is it worth an extra marker in order for what somebody called the Hail Mary pass of, yeah, we want absolutely everything, even though the chances are very small that we're going to get there. The point today, and right now I am going to give you a few results, but it's not to describe how Californians respond to a process like this, because you guys may not care deeply about what Californians think, but it's really to give you an idea of how a process like this can be used to help inform policymakers about the decisions they're going to have to make about trade-offs. And of course, what the whole idea is that you need to talk to the public. So when people are considering their priorities, they're actually making two types of decisions. One, their reasons for including the things they want, and the second, their reasons for excluding the things that they have to. And from our perspective, that's a far more challenging task, and it's the one that is most important for us to learn. So now I'm going to give you just a few of the results. One of the categories on the chapboard is called a quality of life, and its definition for problems in function, appearance, or comfort that are not seriously disabling but impact personal quality of life. And I think you can, yeah, you can probably read that. Infertility, impotence, nail fungus, yada, yada, yada. People in general really like comprehensive coverage. They wanted everything on the chapboard. This one, of course, gave them pause. This is the one that was most troublesome for people about whether it should be included. So I'm going to show you the results, and what I'm going to be showing you are the differences in two ways. The differences on what people with insurance picked and those without insurance, but also how people picked it as a group versus what they picked as individuals. The group being the round 3 where they did it together, individuals being round 4 when they had their final chance to decide for themselves. So looking at those with insurance, only 15% of the insured groups picked quality of life in their package. When they went back to their own computer in round 4, that bumped up to 40%. So in the privacy of their own computer, they wanted to sneak in impotence coverage, but not as a group where they are having to decide together. The uninsured were interesting. The same kind of ratio, but much higher. Only a third of the groups picked it as a group decision, but 60% of the individuals decided to put it back in. And of course, this statement from one of our, for those who can't read it, you want Viagra, buy it yourself. I mean, that was sort of the sum of a lot of people's view about this level of coverage. The other result I'm going to refer to is the restrictive provider network. And I mentioned that obviously as one of the key strategies. This was only one category, but it was a big one. It was a major one because it was very costly. Choice of provider cost you a lot of markers, so people really had to think long and hard about this one. And the restricted provider network was really a primary care model where referrals to specialists are given sparingly, and that really made people choke. Okay, so let's see how they decided on this. I'm starting with the uninsured first. The group decisions, 82% of the groups went with a restrictive provider network, and their feeling was, it's not that they loved it, but to them, it was preferable having a narrow range of physicians to choose from than it was having to give up coverage for any of the other categories or to increase the cost-sharing burden that they would have. Again, when we looked at it as individuals, it dropped to 66%, but still a significant majority. It's interesting, the insured, again, had that same difference between group response and individual response, but a little less committed to a lower level. And, you know, for those of you who've talked with well-educated people with lots of money, choice is very critical to them, and there's no amount of money in the world that's going to get them to give up choice. So even though they were making this for everybody else, the concept of diminishing the amount of choice they had was something that was often problematic. I'm now going to just give you two of the responses to survey questions. Part of what we did with chat was not only going through the exercise, but we also asked them both demographic and attitude questions pre and post to see whether people changed their mind and to learn more about how they think about these things. So this was an interesting question. For yourself, the most important reason to have health insurance would be, and you only had two choices, either to pay for unexpected large expenses or to pay for the routine expenses of health care. Might as well have some fun with you guys. This doesn't take you a long time to think about it. Raise your hand if your choice would be unexpected large expenses as the most important reason. Okay, raise your hand if it's routine. Okay. The insured is about 3 to 1, unexpected large expenses. That was the most important reason. 27% said routine. When we asked this of those without insurance, fairly dramatic shift. Now 52% said routine expenses were more important. And for uninsured women, it was up to 62%. It was the only demographic when we worked with the uninsured where there were any differences in their choices and their decisions and how they answered questions were women. And I think we all know that women make most of the health care decisions. They choose what health plan, which doctor, they take the kids. They're the ones that probably pay the bills. And for them, routine expenses is absolutely critical. This should tell us something about benefits design. The last question we asked, given the rising, and I got tired of animation, so you're going to get me. Given the rising cost of health care, it was a agree-disagree question. Given the rising cost of health care, it is reasonable to limit what insurance pays for. Okay? And they had actually 5 choices: agree strongly, agree somewhat, not sure, disagree, disagree strongly. Pre-chat, we asked this on half the computers pre-chat and on the other half of the computers post-chat, so there was no memory of the question. Pre-chat, 52% agreed somewhat or strongly that it's reasonable to limit what insurance pays for. 28% disagreed, and the rest were not sure. Post-chat, that raised to 76% agreed that it is reasonable to limit, and 14% disagreed. We've asked this question on every version of chat we've ever done, and we get this type of response every time. That going through this process of having to make decisions, understanding that these things actually cost money, really begins to change people's attitude about health insurance and perhaps what we cannot take for granted. Let me give you just very briefly, I sort of feel it's unfair to have walked this through without giving a little bit of the summary of the trade-offs we learned from just coverage. Core attributes: what is it that people really want? Reasonable patient cost sharing, good quality of care, even though they don't have a broad range of physicians, they don't want to give up the quality, and as comprehensive as possible. Okay, that's fine. Everybody can agree with that. What are the compromises? Because that is the part that's really critical. Restrictive provider system, which we went through earlier. High standards of effectiveness and efficiency. Expensive marginal care is excluded, and some needs are not covered. This may sound like a no-brainer, but it really isn't. And that catastrophic example I gave you in the health event was really a way for people to really look at, am I really willing to give up that 2%? And as people started talking about that, it wasn't that they really wanted to, but when they compared it with all the other things that were more important, they felt that this was an easier place to compromise than others. This sort of summarizes and what I hope will be a national dialogue. I actually dislike the term national dialogue because everybody uses it. And to me, it just means, you know, we get to sit around and talk and we don't get to do anything. So I've changed it to national action. And there are kind of 4 general broad areas. One is we really need to have the public understand, and everybody else, the meaning of societal resources. We are so accustomed to healthcare being about what we pay, what we get out of this, but we don't really talk about it in terms of benefits design being something that requires all of society to contribute. We need to look at both the patient and the citizen perspective. And of course, what we've been trying to do with chat is really pump up that citizen perspective, because most people still view everything from the perspective of what do I as a patient want. The question of the individual or group perspective is an interesting one with chat, because I've gone back and forth. Is round 3, where the whole group has to somehow come to agreement? They usually vote. I mean, they vote on almost every category, and often the votes are very close. But is the findings from round 3 more a valid indication of how we should make societal decisions, or should it be based on round 4, where it is the informed individual who's making their decision independently? I have to admit a certain bias to round 3. And the last is about what I call shared responsibility, part 2. Everybody's using shared responsibility as kind of the mantra for where we're going in healthcare, and they usually mean we have to share in the cost of paying for it, we have to share in terms of our personal responsibility, but we often don't talk about how are we going to share what it is that this looks like, and is this something that we can all agree on. The last statement I want to make is a Chinese proverb that I literally stole from somebody else's website, but it was so good, and it so indicated, I think, the importance of public engagement. Tell me I'll forget, show me I may remember, but involve me and I'll understand. The last thing I want to say is I do want to give one more quote, because this is one of my favorite quotes. It was from one of our first chat sessions, and somebody is arguing during round 3 for something or other, and this person says, "I'm just stating why I would want it. We don't have to vote for it, but still I just want to be heard." And that really has been the response of people who have participated. They just want to be heard, and they're far more willing to accept the results as long as they had a chance to make sure that their voice was heard. Thank you very much.
Well, you see why I wanted Marge to come. And now we're going to hear from CELIA about how the voices were heard in Massachusetts and still being heard. The echoes are resonant.
So I'll try to make sure I don't use too many Massachusetts terms, but for the record, I feel like I was thrown into some big chat game, and no one told me we were playing a game here, because many of those choices are things we've had to face in Massachusetts. I'll give very small context. There's 10 of us in a room who are deciding all those questions, and oftentimes it feels like we're speaking in the dark. We started off being told we're going to do this kind of reform, we're building it around the employer-based system, and we have to figure out affordability, plan designs, and what minimum health insurance coverage is, and we had 4 months to do this in. And that was sort of the depth of it. We had no clear sense of the finances. We were building it without the chits, the little poker chips that say if we do this, it costs more if we didn't. And I think what's been really good about our process was that we, by accident, ended up doing it mostly on consensus, so that you might want something, but you might want something more, and to get someone else to agree with you, you had to give on something they wanted so that you could come to a united agreement, because there was 10 of us, and if we didn't agree, we knew it would fall apart in the public. And the second part is there's been very active engagement of the public through the ACT Coalition, through a Greater Boston Interfaith Organization, where they've been testing ideas on members, and the fact that we have meetings for now a year and a half, and there's always 200 people in the room, and all the TVs, and all the blogs. So this is, our decision-making has become a political debate and a public debate over what are the right benefits and what is the best plan design. Now, we started in the context of the Republican governor signed it with the 2 Democratic president and head of the Senate and the House, and we had heard that some insurers had said we could come up with a better plan for $200 that was complete coverage, and that, which in the marketplace up there was $350, $400, so we weren't sure what drugs they were taking, but we had in our minds some $200 benchmark that we had to get to, but based on nothing. I mean, it wasn't based on any actual facts, so we had to come up with 3 plan designs. One is for the uninsured, the people from 100 to 300% of poverty. What was that going to look like? For people over 300% of poverty in the small group market or the non-group market, what kind of plans do they want? What was affordable? And then the simple question that you asked at the beginning is, what was the minimum health insurance we were going to have in our state? because many products get licensed, but are they health insurance? And what did we mean by health insurance? Because we were going to mandate every single person to buy it. So what were we mandating them to buy? And I guess I'll give you 3 different ways. For ComCare, this is where I start using words that you won't understand. ComCare is the subsidized product. It's for people under 300% of poverty. The state pays a big percentage of the cost. It's graduated. But what we built it around, for better or for worse, is we built it off what the Medicaid mass health system was. Because as people moved up, we didn't want people move up and then drop off lots of benefits. They're not our state mandated benefits because they're a public program. So in vitro fertilization is not in the group, but it has dental for a large group, and then it tapers off. So we made the choice to build on the publicly financed Medicaid system, and we made the distinction around networks design and co-pays or premium pays as they go up. And that was really over the only cost sort of pressures we put on it. We had drugs in there, we had hospital, mental health, hospice, homemakers. We have a very expensive program for that. No deductibles for that group, and it's really how much premium will they have to pay. And I'll say this, it goes from cheap, free coffee cups are good. You know, we have signed up, our problem is there's more uninsured than people estimated, so we've signed up about, I don't know, we're 40% over what we thought were the uninsured in the lowest category. You know, we thought there was 60,000. We've signed up 79,000 already, and it's been less than a year. So this is a little problem for us. A good problem to have, but a problem. So what we did was we didn't make any of those choices undecided. What we decided was we wouldn't make them the guinea pig of choices of what we were going to cut out. I think where we did start making some choice decisions was in the people over 300% of poverty. Everyone's going to be mandated. We have a thing called ComChoice because some people on the board think choice is really important. And this is one of the compromises. How much choice is good choice and how much choice is just insanity? And we've done a couple things, though, and I guess what I was going to say to her, and I said off the record, there are many big levers you can pull. Some of them are little levers about what is the design, and then there's some market levers that are very powerful. So as we were doing this, so ComChoice is for people over 300% of poverty who have to buy it on their own or in small businesses. We merged those 2 markets. That alone and the introduction of like a deductible of $2,000 as a floor has meant that for a 37-year-old in Boston who used to have to pay $355 to $385 for an individual plan a month, now can get it for $175. So that merger of that market had a dramatic effect on what people who were buying on their own had to pay out in the real world. We had to look at design. So in that market, there's very few choices for people. If you were, you might have one choice if you were in a small group. You might have 3 total in the whole state if you were a non-group. We had to decide how much choice was good choice. So we created, which is a different concept, I think, than what you were doing. We said all the benefits had to look about the same. We weren't going to water down the benefit package. We would really look at how you pay, how much you pay in premiums, and how much you pay in co-pays or deductibles. And with the assumption, I mean, we had ongoing political debate about the RAND study, and I was on, I'll say this, I'm on the left, so I said, oh, so you made me read this. What it says, if you're rich, or if you're healthy and you have higher co-pays, you're not as likely to go, but who cares because you weren't sick in the first place. But if you're sick and you can't afford it, you'll get sicker and die. That's my end result of it. But sort of this choice of how much do we raise co-pays? What are we targeting in our co-pays? MRIs for lower back pain. Places where it's not effective, we've been able to start targeting that. But in the market, that didn't exist. In our market, less than 1.5% of people have plans with more than $500 deductibles. Massachusetts, why we're expensive, we have a very generous set of benefits, packages, and payments. Most of it comes through premiums. So we had to create a tiered thing of Gold, which is the sort of Cadillac plan. Silver, which is what most people have in the workplace market because we're building around the workplace market. And then bronze, which was our definition of what health insurance was, the minimum that we would call health insurance. This was really critical because for most of us, we were 10 people we have an economist, a health economist, an actuarial, a labor person, a trust fund person, a consumer, governmental people, there's 10 of us. And we were looking at the elephant from our perspective, but not the whole elephant. We were pulling the tail or yanking the trunk, but we hadn't looked at it as a whole. And so our debate about minimal coverage probably got the most press and got the most reaction from the public, the insurers, the small businesses. And we struggled for months on it. We did decide on a comprehensive set of benefits being offered. We did not knock out things. We did most of our cost control through co-pays and or introducing this $2,000 deductible plan that didn't really work out there in the market. I mean, it wasn't really what was being sold. We made limits, though. We said there could not be any annual or sickness limit on what an insurer should pay. There could be no daily caps, so that indemnity plans like Mega Life, will pay you $700 a day for every day you're in the hospital. Little do you know it's going to cost you $2,000, so you're eating $1,300. That was not going to be considered insurance. We set a limit on the deductible, and so I'm on the left. I'm saying $2,000, that's outrageous. And then someone says, well, they're selling $10,000 policies out there, and $5,000. I'm going, they are? Well, I began to think of it as a minimum wage, like a floor to what health insurance should be. Might be what I would want, but we wanted to establish a floor in the market. And we had a 4-month debate on how many preventative care visits would be pre-deductible for each individual. We were screaming 2, 4, 2, 4, 2, 4. You would think we would think of 3 in the middle. It took us 4 months to get to 3 in the middle. And on top of it, then when people bid on these, the insurers bid on these, 5 out of the 6 of the plans gave us all preventative visits pre-deductible. So the lesson is what we, 10 of us, thought was really a fundamental debate about, are you covering the upfront costs like in prevention and maintenance, or the back-end cost of if you have a catastrophe. The market was willing to do, and I think this is where the conversation with the market, with the insurers, with the businesses, and with individuals who are going to be buying is absolutely critical. We had a wonderful argument of which everyone else was much further along and much more progressive than the 10 of us. We also have had a huge fight over drugs. We have voted that we will have drug plans with no more than a $250 deductible for every plan this is the first state that's ever done this, that it has to be part of it. We're now in a huge fight of, can we get the generics pre-deductible, and would we get a better rate if we had a higher deductible for brand drugs? Now many of these people don't have any drug coverage at all, and that's where I on the left have to stop and say, all right, this would be really nice. However, these people have nothing now. So is it better to have free generics pre-deductible and have to pay a whole lot, or have to pay a deductible on brands and make it cheaper so they won't, they'll be able to afford it? Or is it better to say we're going to go for everything and we're basically mandating everyone to pony up a large amount of money? And I think that's what I found interesting about your thing. What is the trade-off, and as against what? I always get caught on, oh yeah, they have nothing now. Who am I looking at protecting? What am I trying to get them? And what are we as a group trying to get them? I probably err more on the sides of not so much benefit. What are the big ways we can change the dynamics in the market? Because when I say there's 100 and 200 people in the room, there's probably maybe 7 consumers, and the rest, all the people counting the money going in and out. You know what I mean? They're insurance companies, so they're all hysterical because we're being prescriptive on what their plans can be, i.e. what makes them different from the next guy if we limit what they can do. And so they're in the newspaper the next day screaming out, we're wrecking the insurance market. We have small businesses have their interest. Well, we want drugs. We're not going to say publicly we don't think drugs are good, but I don't want to pay more than $10 a month more on the workplace premiums, So therefore, just give us generics. We don't want anything else. So I think we need to think about all the financial players and the consumers as people who have a stake in this. And if you're not bringing the consumers in, as she referred to, you're in fact leaving the debate to the people who are just making sure they get their part of the money deal. And that's an important thing to understand, because you don't know it till the next day. You know, we have these arguments. We think we have this totally rational discussion. Next day, it's on the front page of the newspaper that we're totally regulating the insurance industry and we're destroying Massachusetts health reform. I think we had a debate. We ended up with a debate. You've got to protect the front end for maintenance, because if we're not keeping people healthy, what does health insurance mean? But you also have to have a back end protection, especially for lower income people. You know, $2,000 to me, I could survive that. $2,000 for somebody making $30,000 is a huge amount. So we put money at the front end and at the back end, providing both areas of protection. And it seems to resonate with people. People are buying the stuff, though the cheaper it is, the more likely they are to buy. As you go up our things, it's the lower cost ones are the ones that are being bought, regardless of design. They look at the premium, that's it, they've bought it. And the design issues are not something we have done enough out there, the back and forth with the public, to sort of, you know, understand what they want. I'm trying to do this quickly. So the other things I've thought a lot about was, what are the risk pools? The smaller the risk pools you have, and the more design choices you get out there, well, how many of you are either policy wonks or aides to people? A lot of you, okay, right? Truth, okay. It's okay. I think choice. As I came in, I was joking. She's the survey researcher. She's actuarial, and I'm the street fighter. I mean, before I started this, I had no idea what they were talking about. Now I actually understand it, and I don't know that I wanted to, but you know, I think most people want to get care when they need it, and they don't want to have to decide what plan is better for them. They're not thinking through all those things. They haven't been in that discussion. Well, if you do this and you have a motorcycle accident, you're going to be left high and dry. But if, you know, they're not making those choices. They're looking at the premium and seeing whether or not they can afford it with their mortgage or with their rent. And that we need to think about increasing the risk pools, because where we've had, so we did choice, gold, silver, and bronze. Now remember, Mitt Romney was our governor. He ran the Olympics, got him cleaned up. So we have a gold, silver, and bronze level of plans. And what we're finding in the market, gold is like gold, you know, very high end. No one's buying it. So our idea of what we thought choice was, and because only the really sick are buying it, it's going to get more expensive. And because we have a very regulated insurance market, but it's by insured, so their risk is within their whole line of products. So, you know, I'm getting to the point of we should think about one big risk pool for the state. If we're going to make this working and work around the employer-based system, the more we fragment the risk pool, the more adverse selection problems we're going to have, and the more we're going to push products out of the market, because all the sick people will pick them and no one can afford that, and the price will go up. So I think that's a big, I mean, this is a wonky kind of thing, but if we don't understand it, we can create all sorts of interesting packages that will go bust within, you know, the first year, because people who selected it are the ones who are the sickest. And other big, and these are big issues, so maybe this is a little different about benefits, but if you have an unregulated market, you have all these community hospitals that are a third, half of the cost of a teaching hospital. What do you think's happened to our teaching hospitals in Massachusetts versus community hospitals? In the last 10 years, we've lost 50% of our community hospital beds, the cheap beds, and we've had a 30% increase in our teaching hospital beds. They're really expensive beds. If we want to regulate cost, we can look at benefit design, but a much bigger driver is what hospital you're being admitted to, right? And what kind of testing and what overhead costs and what research costs and what graduate medical education costs are you paying in that bed, for that bed, and how do you, in a plan design, so we're working on networks as an alternative. We used to have drug, no drug plans. They would be equal, but you'd either have drugs or not. We're getting rid of it. Everyone will have drugs. We're thinking about having same exact plan, but big network, little network. And if people select based only on premium, they'll probably, they'll take the Blue Cross Blue Shield plan with a narrow network because it's much cheaper. Now, I would bet when we do this, it'll be all over the paper because all the providers will go nuts. What do you mean I'm in this network and I'm not in this network? So the teaching hospitals go crazy. What do you mean you're going to use community hospitals? I think the debate is really among a lot of forces, and it's good to get consumers in there, but the people who are going to write the laws are going to be doing in another room at another time to make sure we don't go too far in each direction or any direction, and we have to keep all those things in mind. I think other things around quality is hospital-acquired infections. We're having a big debate. The insurers are saying, businesses are saying, we don't want to pay the hospitals for a hospital-acquired infection. But what they're only talking about is ones that were clearly a big mistake. But the sort of routine UTI, because no one bothered to check the catheter, they said, well, those just happen. I think if we could look at big things like that and have incentives and health plans around that, we could fundamentally change how the costs in a hospital stay, because we've worked on better quality within our delivery system. And we are actually now experimenting with pay for performance, meaning what levels of quality are we expecting? And if you want increased Medicaid rates, which is what they all want, you have to prove you're meeting quality standards. So looking at the providers and how they provide the care, not just whether I go because I have to choose between the copay and do I want to do it or not, but how you pay providers based on whether or not they're improving the quality over time is really important. And I'll just end with, 20 years ago, one of my friends went up, respiratory therapist in a teaching house, went up to Canada for an internship, NICU respiratory therapist. She said about the third day there, she was talking to the Canadian respiratory therapist. She says, I find this just appalling. If all these 4 babies were back in my hospital in Boston, I could save all of them, but we might lose one or two of them because your equipment's so old. And the Canadian burst into laughter. She says, you're so American. She's like, what? No, I'm saving a baby's life. She goes, how big's your hospital, your town? Same size town, urban center, same size hospital. She goes, and how many babies do you have in your NICU on any particular day? She says, 20, 27, She goes, how many have been here since the time you've been here? She goes, 3, 4. She goes, yeah. We spend our money making sure they never get in here, not on the equipment it takes to take care of them once they're really in trouble. And so I think as Americans, or in your thinking, what is it we need to fund? How do we do that? And how do we control quality and not let the industry drive the new technologies or the MRI centers or the accelerator something or others they need to do research over here? How do we look at the industry as a whole, from the consumer's point of view, from the providers and the insurers, to say where's the cost we can squeeze out? And all of them are necessary. So the design is necessary, but looking at the markets is also necessary. So.
Thank you, Celia. You can certainly see why she's a force of nature in a group of 10 or a group of 10,000. There's no question. Okay, Corey, come tell about Actuaries.
And the first thing I asked her was, do you speak English? Because I don't understand you guys a lot, so she does. So this is good.
It's not going to be technical, I promise. I want to thank Len and the New American Foundation for inviting me to participate today, and especially to Marge, who I think has done us a real great service by trying to focus us more on the benefit side of things and the impact of different benefit designs on cost. Indeed, I think if we don't address the high health spending, then our attempts to achieve universal coverage are going to fall short. As health insurance premiums are increasing, some individuals, even with subsidized coverage, might find their premiums too high. And in terms of public coverage, rising health spending is going to mean further strains on both state and federal budgets. Excuse me. And health spending is growing faster than inflation, it's growing faster than wages, and it's growing faster than the economy. Back in 1970, national health expenditures were about 7% of the economy. And by 2000, that had doubled to about 14%. And now CMS projects that by 2015, about national health spending is going to be about 19% of the economy. So nearly 1 out of every $5 is going to be used toward health. And the question is that going to be sustainable? So we can't just address the high cost of health care, but we also have to address the growth in health spending. Because even if we lower the levels, if the rate of growth still remains high, then we're going to just end up right back where we started from. So Marge really identified the various strategies that can be pursued when trying to put together a benefit package with an eye toward keeping costs manageable. And she correctly argues, I think, that this involves balancing the various trade-offs between these strategies. And Marge's major contribution, and the contribution of that chat exercise, is really to incorporate the public's ideas on how to strike that appropriate balance. So I'm really going to focus on that chat exercise and the just coverage projects that Marge has undertaken. I think that's a really innovative, the chat approach is a really innovative way to look at health spending. And it really helps us shift the paradigm from looking at spending by health sector, by hospitals and physicians and prescription drugs and that kind of thing. And it helps us think of things more in terms of needs and needs-based spending. And as I read her paper and some of her previous papers as well, a few things really jumped out at me. And first was the desire, especially among the uninsured, for coverage for routine services, such as dental coverage versus catastrophic care. And both CELIA and Marge have talked about this. And to be honest, I really don't know quite what to make of it. Because the idea of insurance is to cover low frequency but high cost events, in other words, catastrophic risks. Now, admittedly, health insurance is a bit of a different animal here. It's protecting not just financial security, but also your health security. And for that reason, routine coverages, routine services are often covered in a health insurance plan. However, what happens, especially if you look at dental coverage is a very predictable, manageable kind of expense, and when you get a lot of, and part of the reason it was chosen because the thought was that everybody's going to use it. Well, what happens when everybody uses a particular service, the costs for that service are going to be added to the premium pretty much dollar for dollar because everybody's using it. So I don't mean to imply in any way that people's preferences here are wrong, but I mean, that's what they are, and I can see where they're coming from. But I'm wondering if this points to some kind of need just for maybe a little more education or information on kind of a health insurance basics kind of thing. Just a shameless plug here for the American Academy of Actuaries. We're actually putting a paper together on some basics on health insurance coverage. So hopefully we'll be getting that out to you all soon. I also wonder, I also don't necessarily want to put too much into this because the wording, I think, for the advanced tier, the higher tier, the catastrophic, was kind of worded in a way that I think might make it pretty easy for people not to choose that. I think the wording went something like treatment that has very little chance of helping you. Well, I went to Boston College. I was there during the Flutie years. I am very partial to the Hail Mary pass. But even I think might find it pretty easy to kind of let that category slide. So I'm wondering if the categories were rejiggered a little bit within the tiers, that maybe there would be more difficult choices there. The second thing that jumped out at me was, and Marge has talked about this, is the willingness that people had to have more limited provider choices. And I think that this just provides a further argument for presenting the choices in this kind of manner where people explicitly see the trade-offs that are inherent in their different choices. And I also want to stress that this chat model focuses on how much, when that pie chart is determined, it's made up by how much different categories contribute to spending. But I think it could be even more valuable if it considered how those different categories contributed to spending growth. And for instance, if we look at that complex chronic category that's in the chart, I think it might be the case that that category has higher spending growth than some of those other categories. So maybe a way to reflect that is to require even more markers for those categories. And on the flip side, something like dental coverage might have lower spending growth. So maybe you could get away with fewer markers for that kind of thing. So in that way, maybe you could incorporate spending growth into this exercise. And finally, I think I would lose my actuarial membership card if I didn't at least mention adverse selection. CELIA mentioned it, so now she's an honorary member, so whether she likes it or not. I know what it means. In the context of this discussion, adverse selection could arise when people are offered different types of benefit packages. Now, all other things equal, people who are at higher risk for having high health spending down the road are going to be more likely to choose more generous benefit packages. Now, this might not be a big deal when we're talking about getting coverage for the low-income population. This population may all be choosing that basic coverage plan because they can't afford a more generous plan, even if they're at higher risk. However, if we're using this kind of strategy to also think about the benefit coverage plans for middle and high-income people, then that's when adverse selection might come into play, because that the people who are at higher risk for high health spending, if they have that extra money, they're going to choose that more generous plan. So I think it's just something to consider if this is used more broadly. So just to sum up, I do think it's really important to have a public dialogue, or should I say public action, to help better set our spending priorities within health. But I don't think we should even stop there. I think this is a really useful exercise that we can apply on a broader context. And I think we could use it to look at, to help set our spending priorities between health and other national priorities. And I think this is just going to become more important as health spending becomes a greater and greater share of the economy. And finally, I can't stress this enough, it's important to not only address spending levels, but also spending growth. So thank you, and I look forward to more work from Marge.
Okay, well, I certainly think we're probably going to have a number of questions, and I want to turn to that in just a minute. But before we do that, I want to call attention to a card that Elizabeth's about to hand out, because what we want to give you is a chance to let us know if you'd like to learn more about CHAT specifically. We have already booked 2 tickets for Marge to come back, so we're thinking of bringing her back and actually setting up a situation where either staff or maybe even some of your bosses would actually play CHAT, because we think, in fact, this could go a long way toward moving a dialogue and having people on both sides of the aisle see they, too, can understand and agree about trade-offs. So while Elizabeth passes those around, if you'd like to just give us your email or whatever, and we can definitely get back to you, and you tell us if you're interested in more. So now let me open it up to any questions that may have arisen as we have gone through these presentations. Maybe I should start with Marge. Did you have anything that you thought you should say in response to the comments that have been made?
Yeah, I think I had forgotten to mention, I want to make sure people understood in terms of the actuarial role, because I wasn't sure that I had mentioned that the number of markers that were part of the chat board were actuarially based, that we worked with Milliman to actually try to figure out what the value of each category and each tier was. And that really was an important aspect of people beginning to understand that different things actually have different cost implications to them, and that was a real aha. And I just wanted to comment about the last comment about perhaps CHAT can also incorporate future cost growth and what that means. And Marian Danis, who Len acknowledged earlier here from the NIH, and who is the co-creator of CHAT, certainly knows this. One of our great challenges with the game itself is that there's a tremendous amount of information in this process. But when I first started looking at it, I asked Marian, 4 rounds? Why do we have to take so long? Why can't we just do this in a couple rounds? And she said, trust me, you'll learn. people need that time to really both understand the decisions they're making and to really begin to make those trade-offs with some degree of insight. And it actually takes 4 rounds, and nobody complains about it. They really are starting to feel comfortable with this. So my point was that one of the suggestions we often heard from people, and this has to do with your comment, was that, you know, if we put markers under the maintenance category, which happens to be sort of early chronic illness, to avoid people going into complex chronic, which is late chronic illness, it seems to me we should be able to reduce the number of markers required for complex chronic. So if we give them tier 3 of maintenance, don't you think you ought to take off at least 3 marker spaces? So, because we know that this is all about prevention. And of course I would tell them, great idea, we'll just tell the people who devised this to figure out how to do it. In fact, there really are limits to what you can do with any exercise in 2.5 hours. And most important, limits to what people can absorb. So when we create a new version of chat, which we often do for whatever group we're working with, we always have to keep in mind, whether it's lay people, whether it's healthcare providers, whether it's industry people, whether it's policymakers, we've done them with all groups. They all can only absorb so much information. And what we're after is delving deeply. How do they actually make those trade-offs? So problem is it's really difficult to include more things than I think are already on there. But it's a great idea.
Okay, great. Okay. Yes, it would be helpful, I think, since we're on C-SPAN, to stand and tell us who you are and where you came from.
Okay. I'm Diana Porter, the Alliance for Retired Americans. I wanted to ask Marge if you could tell us a little bit more of the demographics of the group. For instance, the age range. Did you include people on Medicare in this consideration? And then also, did you find other noticeable distinctions, such as the uninsured women, and how they, talked about their priorities of health insurance? Okay. Did you notice anything else in particular demographic
your
groups?
Second question first.
Maybe
No.
you could kind of repeat the question.
Oh, sorry. Let me repeat the question. The first was what was the age range and general demographics of the people who participated, and the second question was, were there any other differences in how people responded other than by gender? And let me differentiate, first of all, both projects, because the first one, we weren't concentrating on the uninsured. So that first project where we did 71 groups, we were looking at it as we were opening it to anybody who wanted to participate, even industry people, because we were taking it from the perspective, you're all citizens. And this is a big question that we, the citizens of California, have to address no matter who you are. So we didn't have too many uninsured in that group, and we didn't have too many low income and too many folks with less education. We did have some. We didn't discriminate against Medicare folks, but nor did we target them, because the premise of this was expanding coverage for the uninsured, period. So if people were over 65 and wanted to participate as a citizen, great. But we didn't focus the game board on what the benefits would be for a Medicare population or a Medicaid population or a healthy family. So people knew that this was just for the people who are currently uninsured and didn't qualify for public sector programs. I have my water. Sure. The second part of your question, which was with the uninsured, and there was almost no demographic difference, and Kathy, correct me if I'm wrong, in the first project. We did by age, by gender, by education, by income. There were some small differences of people with lower education or lower income in some of the choices, but they weren't really dramatic. The second phase, which was only the uninsured, and it was only 121 people. So you know that if you're going to see some statistical variation that has a decent p-value to it, that it's going to have to be pretty dramatic with 121 people. So we did our due diligence and all our comparisons, couldn't find anything except for women having to do with the cost-sharing piece. And I'll give you another example of that. One of the wedges on the pie chart, of course, is the co-payments. And if you wanted really low co-payments, you had to go up to tier 3, where it cost you more markers to get low co-payments. Very few people did that. Most people stuck in the mid-range. But of the very small percent, I think it was 12%, that went to Tier 3 for copayments, low copayments, 3 to 1, it was women to men. So that was just sort of one other validation that low-income women are particularly concerned and cautious about routine cost of health care.
See you. Sure.
Did you look at race at all within that group?
Yes, we did. And we also really, when we recruited for the uninsured, which we did all through paid focus groups so that we could really target the demographics we wanted, and we really tried very much to make sure we had ethnic diversity. No, there was no ethnic differences.
Good. Very good. Yes.
I also have a question for you about the chat program. And I'm Amy Allena from the National Women's Health Network. You talked a little bit about where infertility fell in the conversation, and I'm curious about some other maternity or pregnancy-related questions and whether you talked about them and how they were categorized, both contraception and whether that's considered maintenance or quality of life or where that falls, and also about choices in childbirth, whether that came up at all, choice of provider, care by a midwife as opposed to an obstetrician.
Yeah. Interesting question. We've talked about contraception till the cows come home, and we've dealt with this with every game about whether we should include it and if so where. And I made a executive decision to keep it off. And the reason is, first of all, it doesn't really fit into anything, but there is a national consensus that it should be covered. And so sometimes you don't ask the questions that you already know the answer to, so people spend the time on the things you don't know the answer to. And the second question, the maternity benefit that was up there, the provider thing is separate from that. So the definition of maternity didn't include choice of provider. One of the interesting things, and it was kind of a fun category, we didn't know what to do with it to get a Tier 2. So we decided we'd call Tier 1 all the routine aspects of childbirth and pre- and postnatal stuff were covered under Tier 1. But if anything unusual happened, you'd have to go to Tier 2. By the way, they all picked Tier 2, so relax. But what was interesting is that under our definition of what was out of the ordinary was C-section. Boy, last time I do that. Because everyone sees, and I finally actually changed the wording to emergency C-sections, because everyone considers C-section routine. And that's a problem, as you know. So, but even including it as emergency C-section under Tier 2, people would have picked that if only for that, because everybody they know has had a C-section. So, but who they have as their provider would have been in the provider category.
Celia?
So I'm interested in the difference around the maintenance and the importance of maintenance and prevention. It sort of goes to what you said of what is insurance for versus what is health insurance for, and whether it's to keep people well or is it to deal with catastrophic things that aren't likely to happen to you. And how did people start talking or thinking about that? You said women wanted more of maintenance. I think that's some of the subterranean debate on our connector board is what is insurance for? You know, certain people thought it was going to be a $100,000 hospital policy with nothing else paid for versus keeping people well in society. And what is and so how do people sort of struggle that out or talk about it?
Well, I think most people realize that most people think that health insurance should be for all of that. So they don't make, you know, back in the olden days, it really was considered catastrophic, and as increasingly it started covering more and more things, people have grown to believe that some people resented that question, what is most important, catastrophic or routine, and had a hard time answering it. They ultimately did. But in fact, people really regard it as something that should cover both things. So then that's when you have to start questioning then, are there aspects of the way we're delivering care that can be changed in order to give people what they need? The $100,000 payment for the hospital, I mean, we have to ask ourselves, why do we even have insurance? Is it to protect the hospitals from bad debt? If it's to protect the hospitals from bad debt, then all you need to do is provide the coverage, you know, provide them with a $10,000 high deductible, and then cover the rest, and the hospitals will be pleased that they're not going to eat the $200,000 bill that otherwise. But I think people regard it as something more than that over time, that it is something that is perhaps as important to us as a society as basic education is. And therefore, it really is more than just the high deductible for the hospital.
Be interesting to see if that changes once Corey's paper is out in public and you're teaching us better about what insurance is. Yeah. Yes, in the back.
Hi, I'm Joanne Volk with AFL-CIO. Found this all very interesting, and I think one of the most significant benefits of these kinds of processes is that you get this public buy-in to this notion that you can't have everything. We have to start to think about limits and what makes the most sense. But I guess I'm wondering where that intersects with what we also talk about sometimes with evidence-based benefits and just looking at it from an objective standpoint. I guess I'm not surprised that in a room full of mostly insured higher-income people, we value catastrophic coverage more than routine because we want to protect assets and can pay for the, more likely to pay for the out-of-pocket costs of routine care. So I'm wondering how that comes in. I mean, you had this example of surgery that had a 2% effectiveness rate. How do those kind of objective calculations come in, and how much do we defer to people's preferences, even if they don't necessarily make sense with what's good medicine or what health insurance really should be for?
Well, first of all, actually, I do want to respond to the not unjustified critique that maybe we set up the second tier of catastrophic too easy. But keep in mind, with the health events, amazing to me, it was always amazing to me, people took these very seriously. I mean, they really took them as if I was somehow, a gypsy who had just read the crystal ball of what's going to happen to them and their friends. And so they took them very much to heart. So the fact that the catastrophic health events always made them regretful. I mean, that was the purpose of the health events, to make them regret that they only picked tier 1. Because otherwise, it wouldn't serve its purpose, to make them think hard. So people struggled with that second level, even when we described the benefit as being fairly small. And maybe 15% of the uninsured actually went to tier 2 in round 4, even though they didn't pick it in round 3. But ultimately, when people are trying to make decisions, one of the key values that comes out of this is how many people are affected by this. I didn't talk much about sort of the global values that came out of it, but number of people affected is really major, and that has been true in every chat version we've done. So if you have a low incidence of something, people tend to think, yeah, it's too bad, but in fact, it really might be better to use the marker for vision care, where we know so many people need it and so many people can use it. We don't want blind drivers and yada, yada, yada. So that is really, I mean, it's one of the real findings we've learned in the last 5 years, is this issue of the number of people who benefit. Now, we also know that you have that horrible catastrophic story on the front page of the Washington Post that says, small child denied by health plan because yada, yada, yada. That gets into one of the other values we have that really conflicts with this, and that's the value of compassion. And we have compassion for the individual incident that happens that is just horrible, and our heartstrings are tugged, and we can't stand the fact that the small child might be denied every last chance. But when we're making decisions as a group, we say, you know, our job is to watch out for everybody. That's what we are here for, so let's make sure that as many people as possible benefit from it. I don't know if that entirely got to your question about the catastrophic, so tell me if it did.
If I could just follow up with CELIA, because you talked about in Massachusetts, you were starting to look at things like different co-pays for MRIs for low back pain, where you had, I guess, some confidence that the evidence base was strong enough it could persuade you. Could you speak to that question, Joanne?
I guess I'd approach it in a little reverse form. We have more uninsured than we thought. We have a limited amount of money, sort of like your game. And so now we're having to say, well, we really are doing a good job of signing them up. How are we going to keep paying for this? And are there things that we can tweak that we had this ongoing joke about John Gruber and his MRI for his elbow, for tennis elbow, right? You know, we shouldn't pay for MRIs. I've had 3 of them, blah, blah. So, but we got then to the discussion of what are the things we need to start thinking about other than just shifting the cost to people who are poor and aren't going to be able to pay it, so they're not making medical decisions just on a financial basis. And so now, so year 1, we talked about them, we didn't put them in the benefit design. We are now talking about, could we raise copays on some of those things that are not necessarily good medical, cost-effective things? Should we have a higher copay for MRIs than what we do now, and maybe be specific for back pain, because it doesn't appear to, but that's so new. We're also very afraid you do something in the market and it takes off and you've created a disaster you never intended. So we're being sort of cautious. I'd say another thing your talk made me think of is we had a huge free care pool, meaning we paid for people who went up to DISH hospitals, the disproportionate share hospitals, and the emergency bad debt of hospitals. We are paying for the back end, for the uninsured, with this huge pool of money. CMS wanted us to turn it into insurance and not paying for those hospitals and bad debt, sort of the original reason, and they wanted it into insurance. We bought into that for whatever reasons, but what it is shifted is the money is more towards prevention than it was in the back end, and it's costing us 2 to 1. So you could just pay for the bad debt when they ended up in a hospital, and it's going to cost you twice as much to add prevention on. And I don't think the political debate that got us to make that shift, I'm not sure anyone thought about that result, that going from paying hospital debt to paying for preventative and the full spectrum of insurance was going to cost twice as much, and that it was a different place where you're putting the money. So we're debating some of that stuff. I don't know if that's enough of an answer.
That's great. That's great. Marion, you were going.
I wanted to just mention a couple of things that entered our minds as we designed chat. And one goes to the heart of what you were asking about. How do we balance input from experts who know about the utility on an evidence-based set of data versus getting public input? And I think that our whole rationale as we designed the chat exercise was to create a tool that allows the public to engage in policy decisions based on input from experts, so that it's very crucial to realize that the options that are put on the table are going to have a large impact on what comes out at the other end. And what might be most useful is that those who design the options think about cost effectiveness. And the original, a lot of the thinking behind this is that what was to have the tiers be reflective at times of more and less cost-effective things, so that you have people who may not understand issues about cost-effectiveness and diminishing marginal utility as you offer things be guided in their deliberation to make choices that are prudent. And the other thing I wanted to say in response to Ms. UCCELLO's comment about the fact that we are talking, the chat exercise was designed to think about health care options. We've actually designed a version of it that tries to address the fact that we have lots of priority setting issues that we face. And we recently designed a version of the exercise called REACH that stands for Reaching Economic Alternatives that Contribute to Health, with the idea in mind that for particularly low-income people, health insurance alone is necessary but not sufficient to guarantee reduction of health disparities. And we've designed it to allow for incorporation of options like other things that might be offered to low-income folks that could contribute to their health. And I just wanted to let people know that that tool is freely available to anybody.
Excellent. Marjorie?
Yeah, I just remembered actually one other, that I think Marion was starting to talk about, one other comment you asked about, which is What do we do if the public's decisions are really kind of lousy ones? and I do acknowledge that in the paper, that the public's values are not alone determinative, that they don't always make great decisions, and neither can policymakers ignore them. Because a lot of part is, how are they thinking? What are they thinking about this? And what can we do to meet those needs that they talk about? It may not be perfect. They may not get a benefit plan, a vision plan in a basic benefits package, because I'm sorry, guys, you're just going to have to go to Walmart and spend the $99 yourself. But if there's some way that one can recognize that these are issues that are important to them and find perhaps other compromises where some of these really important things get met, then that's really important. But it doesn't mean that everybody has to accept it whole cloth. So,
Owen.
Hi, Alwyn Castle with the Center for Studying Health System Change. First, an observation when we talk about evidence-based care, there isn't much of an evidence base for most of what we do, and comparative effectiveness, I think, has gained more currency, and there is greater recognition of the need to do more of that, but we're not anywhere near where we need to be. Secondly, I'm curious about what was the response about end-of-life care, and where did that fall? And I would point to the example that you used in your slideshow of, $100,000 to extend 5 months of life. I think this goes to the heart of how healthcare is different than other kinds of goods and services. Healthcare is not hog bellies. It is people. And it is compassion, and I think Americans have the greatest compassion in the world for an individual case. Somehow or other, we've allowed our health system to develop into a system where, we don't let people bleed to death on the streets of America, but we let them die quietly in the corner because they don't get things that they should, but most people don't know that.
Sacramento Healthcare Decisions also does a lot of work in end-of-life care, so I couldn't resist putting that in. That was a fun category, if you will. Tier 1 was the hospice benefit, basically, for somebody who's terminally ill, 6-month prognosis, that sort of thing. Tier 2 got you the hospice benefit, but if you preferred, you could stay in the hospital, in the ICU, continue to get life-sustaining treatments, even though all hope is gone. You were waiting for the miracle. You weren't ready to give up. I was surprised that virtually all groups picked end-of-life care at all, even Tier 1. And I would often challenge them if there wasn't enough debate. I would say, why, this is a population that's under 65. Not many of them are going to die. They've got family. They can take care of them themselves. Why do you guys want to waste a marker on end-of-life care? Because I really wanted, and this is one of the ways in which that whole compassion issue comes up. And people would say, because that's one of the reasons we have health care, is to make it easier and comfortable for patients and families at the end of life. And it was sort of like, duh, what a dumb question. Of course we're going to include it. But it was important to really find out what was it about that made it so critical that it belonged in a basic package. And people only occasionally would somebody say, this is silly, let's not waste our marker. But that was very, very rare. Very few people fought for the ICU for the second tier. Very, very few.
Yes, in the far back.
I'm Alicia Carey
If you
Jones.
could wait for the mic so C-SPAN would be happy. Thank you.
I'm Alicia Carey Jones of the American Optometric Association, and I've had this question prior to your comment about vision care versus dental care, but given that case that was on the front page of the Washington Post, it has gotten a lot of legs for the right reason. However, we haven't seen vision care in a lot of the public programs that are on the Hill right now, and it's not in the SCHIP or the authorization. So I didn't know if you had any, how many people chose the vision care, and
It was much more popular among the uninsured. In the insured group, in the first project, I think vision care, I don't know, I don't remember, Kathy, maybe you remember, it was very close in the group settings to be covered. It may have not quite made it for coverage in the group settings, but a few more people in round 4. But in the uninsured, it not only was covered in the group setting, it was also covered by the individuals. And so the argument that it's one of the least expensive things that you could buy for yourself just didn't carry a whole lot of weight with the uninsured. I mean, they just still felt that, you know, if you don't help people pay for it, and it was a pretty skinny benefit, if you don't help people pay for it, they're not going to get their eyes checked, and they're going to hit me on the highway, and they're not going to keep their jobs. They're all going to be blind. I mean, people were very dramatic about what's going to happen if you don't have vision care. So that was one of the differences between the uninsured and the insured, and why, I don't know, except to speculate that when the day is done, people do tend to gravitate to the things they know and the things they use. And as I said before, also the things that most people would want. And even though it might not make any sense economically, you know, this is just something one has to take into account.
Yes, right here. See, yeah. Okay.
Just vision versus dental, did you see
Yes.
a very close
Vision or
comparison?
dental had almost no discussion because everybody wanted it, period.
Okay. See, did you want to add something on?
When you did this with folks, did you do, I mean, my sense as a labor leader is that oftentimes when there are lower cost plans introduced in a place, you will see over a period of 5 years, suddenly people go to cost. The premium cost is what drives people to plans, not the benefit structure as much. And did you find after this that people were more thinking about the benefit structure, or they were thinking about the benefit structure to get the cost low? You know what I'm saying? It's like a regular person I represent might say, oh, yeah, can I do that? No, I'm going to pick the lower one. They're not looking at the benefit structure. They might look to see if their doctor's in there, and that's about as far as it goes.
Yeah. Most of the time, it's the first value we list in the first just coverage report was affordability. So absolutely the first thing they care about is, can I afford this? Is this going to work out? And then they look at benefits design. I think people are very trusting, and I think we're seeing this in some of the research about the HSAs. People assume that this is going to be decent. They assume that somehow if somebody's put together a benefits package that it will be fine. So I think one of the outcomes of our various projects when we've done it with employees is they're going to start paying a little bit more attention to what's in their benefits package, because for the most part, people really, really haven't been.
Okay. Yes.
CELIA Benzon, University of Virginia. I have a comment for you. I thought that your result with uninsured women and their emphasis with routine care was very important. And I have two questions. One, the center of my research is on violence, and I was wondering if you found any cost containment measures for women who might be in the middle class economic range who suddenly find themselves going to a shelter, leaving their spouse, and having that financial turbulence that they have to deal with, especially when they have children. And two, if you found any facts regarding violence on your areas of mental and behavioral health or prevention.
We didn't focus on this as an issue, so it was rarely raised. I think it may have come up a couple times when people talked about the mental and behavioral health category in terms of people's needs outside the most dramatic, profound mental health problems, schizophrenia, bipolar, that sort of thing, when they talked about the needs people have for mental health services for other things. I think it may have come up at different times then, but it was really only in passing, and it wasn't a focus of our discussion.
Yes, Bill in the back.
Hi, I'm Bill Kramer, Oregon Health Fund Board, and consultant with the Oregon Business Council. I was intrigued by the way you asked each of the respondents or the participants to respond as citizens rather than as private individuals. And I wondered if you could share what you learned about that, or could perhaps speculate if you hadn't emphasized that citizen aspect, would you might have gotten responses or preferences that were different.
It's really hard for people to do that, and everybody starts certainly in round one, even though we've given them very clear instructions. They still said, okay, let's see if this was me, and then they design it around their needs. What helps us get to the citizen hat is not only constantly reminding, but when they have to debate with their colleagues, This often happened in round 3. Somebody would make a pitch for something and someone said, but you're just thinking about yourself. Remember what we're here for. It's not about you. And so they would remind each other constantly. It came up when they would talk about why they would want to support the mental and behavioral health category. This was a very interesting one and a very interesting difference between the insured and the uninsured. The insured particularly wanted to get to at least Tier 2, which covers a lot of behavioral health services for substance abuse and the like. And the reason is they really saw this as a societal imperative, that we've got to keep people at work, we've got to reduce the crime rate, which is secondary to drug abuse, and they really were wearing this broader views of society, and that's what makes it important. That probably was the most obvious one when people began to see what it meant to make decisions as citizens who are responsible for all the repercussions of their choices. It was less evident with the uninsured, who have strong feelings of personal responsibility and did not want to fund substance abuse for people just like them. You know, they quit smoking, they stopped their own drinking problem, everybody else can do the same. So they tended not. They were much less convinced about funding that level. I think people still struggle with it the whole time. It's still hard for people not to think about if this were me. But I think they're able to do it pretty successfully. And I think by the time they're done, they really do begin to see this in a different light than they did before. And I don't have anything substantive to offer on why I think that's so, except to say the way they talk about it.
In the back, yes.
Al Milliken, Washington Independent Writers. Would any of you be able to make comparisons, any significant differences or similarities these potentially have with health care coverage in other countries such as Canada, Britain, France, or Cuba? And did anyone have a reaction to how Michael Moore's CICO has helped or hurt health care coverage for Americans?
I'll let the street fighter handle that one.
I guess I'm on the left, so I get the Michael Moore question. Since I haven't seen it, I'm not going to answer that. Though I do think the story I told at the end about the respiratory therapist was about the difference in ability to budget and to set priorities on a governmental level, so that money went to prevention, well baby, prenatal screening well baby, so that the babies never ended up in the neonatal care, and that as Americans we are so, you know, we think of it as the ICU, what happens if I get hit in a motorcycle or I have a stroke, and what am I going to, who's going to take care of my mom when this happens, that we don't think about the front end as much. And, you know, I think that's part of what I found interesting. I was going to ask her, has she done it in mixed groups of having a provider, having an insurer, having some uninsured, having some insured, you know, groups that come at the elephant in different directions, because I think in America we've only come at it in one direction for a long time. And the side of how do we control costs in health is a public health, like how do we look at the health of the nation and where do we set priorities of where the money's spent? And I think Michael Moore's, what I know about it, raises some of that. And, you know, my friend coming down from Canada, or Canadian friends who are in school and they break their ankle and they show up at the hospital and they're looking for cash, and they're like, well, if you friggin' came to my country, we wouldn't ask you for cash. They have no comprehension of our lack of sense of obligation to provide health to people. It's just foreign to them. And I think, you know, this kind of discussion among all of us about what are we attempting to do with insurance or with providing health is, you know, if you know Canadians, they think we're nuts, generally speaking. Like, you have to pay what to get in the door? I mean, it's foreign, and they've been they've grown up in a different environment with different social and societal expectations of what care is.
Occasionally somebody would really be unhappy about even participating in the exercise, because they would say, we shouldn't have to be making these choices. We should have 80 markers, and it should be an 80-marker board, and we should be able to get it all, and that this is a false premise, that if only we had X, Y, or Z, we shouldn't have to be tinkering with the benefits plan. And, you know, there was a a valid complaint and something we acknowledged, and then they stayed and they played. And they usually, because it's very stimulating. It's both fun and stimulating. But yeah, I mean, it is a complaint of many people that we shouldn't have to be making these choices about benefits design, and perhaps if we had a different kind of system, we wouldn't have to.
Marge, how about Celia's question about having very heterogeneous groups play the game together, insured, uninsured, very high?
I'm thinking the connector board.
Yeah. Hey, I'd love
Would y'all like
if
a chat demonstration up there? Would that be fun?
No, I'm just like all the players in a room having to sort of put off their hat of, and have you done that? And what kind of reaction?
Not in quite as structured a way where we went out of our way to pick certain folks. Some of the groups just happened to be organized so that it was pretty mixed. There's amazing consistency, actually, because we ask people, we might ask them to wear their citizen hat, but what we're also saying is this isn't about your day job. This is about what you value as an individual, as a citizen, not as somebody who works for HealthNet or Kaiser or whatever. And, you know, they can't entirely take that hat off. That might inform some of their decisions. But when you ask them to do it as an individual, thinking about your own personal values of what's important, there's far more consistency of theme than one might have expected.
I wanted to give one dramatic.
Sure.
Our debate about whether we do drug coverage. So you have the small business representative on the board, and we were obviously fighting a lot. So we had some offline, like going around the rooms, you know, soul searching, like, would you buy insurance without prescription drugs? And what was interesting in those conversations, the day that we were coming in to make the final vote, the business guys ended up voting again for it, for drug coverage, because, you know, when we got to the discussion of, do you really think people should not have coverage on that, they couldn't say, you know, and it was fascinating because they were on the press 3 days before saying how outrageous this was. But I think that sort of personal, do you really think that?
Yes.
Versus your role as protecting small business, is that what you mean by health insurance? And we were very open about it, so that, you know, we had gotten enough trust at that point to be able to have those discussions.
Very good. And how long did it take to get to that level of trust?
I'd say at least a year. You know, it was a 4-month debate on drug coverage, of which meetings in public and meetings behind the scene and meetings in public and screaming and press, and then we finally did it. So.
Very good. Enrique. Wait for the mic, if you would. Thanks.
Enrique Martinez Vidal, the Director of State Coverage Initiatives Program at Academy Health. It's probably a question for Marge and also for Celia. Looking at the, sort of going back to the question about the safety net system and the relationship between the coverage system, was there any discussion in your groups or at the connector board sort of what the impact might be if something got left out of the benefit plan and then the people would start having to turn back to the safety net and use either community health centers to do what wasn't being covered, or inappropriately using emergency departments or those sorts of things? I mean, we saw that in a lot of the work that we did previously on limited benefit plans, that there was, you know, a real cost shift question of just taking the money out of the coverage system and shifting it back into the safety net system.
Well, actually, Tier 1 of providers, one of the first, you know, people resisted this restriction, and particularly about restrictions to specialists, and ultimately voted for it. But one of the big challenges was describing to them what Tier 1 looked like, because right now we don't really have a Tier 1 providers except maybe the safety net clinics, the public health clinics, you know, the county services, sort of what San Francisco is doing right now. And I'm sure those of you are following that. So that really was Tier 1. And I think the outcome is that, you know, whatever this lower cost system looks like with limited provider choice, as long as they know what they're doing, then that's okay. We're satisfied with them. So if one were to actually try to implement chat, safety nets would be secure because that's where, in fact, their services would be had.
See you.
I think our debate, truth in advertising, I used to work at Boston City Hospital for 14 years before I got into more trouble and I had a different kind of job. And so I think I was always, I am an advocate of the dish hospitals and the sort of, but I think through this process I've learned that, you know, we gave money to providers and those providers, and they owned the patients. The patients had to come to them. So when I was young, you know, we'd have an appointment system in the old city hospital where if you're uninsured, it was 8 o'clock in the morning, which meant come at 8 and you'll wait till they'll see you, which you would never expect at a Harvard Vanguard or any of the, you know, you would never put up with it if you were insured. And this has done a couple things. One is patients now have choice. So those dish hospitals will be chosen, assuming they do treat them right and don't treat them like they own them. Secondly, we've allowed the MMCOs, the plans we're offering for the uninsured, to be based on those dish hospitals. So the plans that are cheapest are, in fact, the big dish hospitals and the community health centers, because they are more cost effective. The question is, do they treat people right so that they want to keep coming back, because in a year they can choose to go somewhere else and pick another plan that doesn't use them. And then I think there has been some holes, like we're thinking about increasing ER charges for people in the subsidized stuff, because for the last 20 years we've trained them, show up at the ER because we'll pay for that through the free care pool. We won't pay for you to go to the doctor. So now we're having to retrain people, say, no, it's going to cost you $100. Why don't you make an appointment? We're not doing that anymore. That's not their fault. That's our fault. And secondly, we're saying that the free care pool has to mirror what insurance is, because if you can still put it off and go into the ER and it won't cost you anything, why will you sign up for insurance you might have to pay $75 a month on? So we're having to model the cost for using the free care pool to model what it is to have insurance, and isn't that a lot better, because now you're totally insured as compared to waiting till you end up in the ER. So those are some of the, I mean, I could go on for hours about that one, but they're, you know, do we charge people now when they come in for free care? And who's allowed in there? It's now part of the debate.
Isn't it great to have Massachusetts doing this experiment for us and learning all these things? We thank you very much.
All of the bad things we do.
I appreciate it. Yes, ma'am. Could you?
Hi, I'm Deborah Reed from the National Health Law Program, and I think just in light of the current environment on S-chip, I was wondering if the panel found any perceptions on how kids should be covered in your work, particularly low-income kids and undocumented kids, too.
Yeah. I'll answer that very briefly. We actually set up just coverage to not include kids, to show you how, well, I'm not sure it was naivete. We thought it would be a harder question. We were working under the assumption that eventually, in fact, all kids would be covered. And in previous chat games, kids were covered. I mean, but we decided we really wanted to focus on the adults because that was going to be the harder question. So one of their rules of the game was this was only about uninsured adults. It wasn't about kids. But I will say that in some ways that made it easier for people to say yes or no, because when we've done it with kids, a lot of the hang-up, like even the Tier 2 catastrophic, to think that you weren't going to do everything possible for a child really was different than not doing everything possible for an adult.
Celia, I know in Massachusetts the mandate doesn't extend to children, so does that?
No, but this is where politics gets really fun. The mandate is on adults, and we have a very generous S-chip program. During reform, we moved it up to 300% of kids. They cost like $24, $28 at the most for kids, and if you have more than 3, we cap it at 3 payments. But now we're going to require the adults to buy. So you might have 3 kids and be paying $84, and now we're going to say you're making $45,000 that you're going to have to pay $105 for you. Hello, do we think they can do this? So as a political compromise, as we set the subsidized rates for the like 250 to 300%, the political compromise from the governor was, if you sign up as an adult to meet the mandate, then the kids you've already been buying for or the kids you have will be free. That we have this sort of moral, we want the kids covered, we have been able to do that, and now that adults are being required to do it, if you've been doing the right thing or if you have kids you want covered, we will pay for that if you sign up and start paying as an adult. And it's been really good. Whether we can maintain it with the S-chip things, one of the reasons we're, we haven't gotten rid of the free care pool is this thing has a lot of holes in it. you know, if you're working, you can't get into the subsidized products, but it might not be affordable. We're going to have to keep paying for those folks. People who are not documented with the, you know, the tightening documentation and stuff, we're still going to need a free care pool because there's got zillions of holes in this. I'd much rather be in a single payer system where everyone's in there than trying to build around the employer-based system. But we've had a very strong pro-kid stuff, and the governor's been able to come up to the plate on that.
Yes, one more in the back.
Al Milligan again. On page 18 of your New America policy proposal, the blue box does state what Abraham Lincoln once feared, that our government could not endure half slave and half free. A nation that is half insured and half uninsured may prove similarly unstable. I mean, do you think it is possible we're on the verge of a civil war?
I would say that, you know, that was a metaphor at the end of a long night, but I would also say that, in a sense, the point is that society either has a sense of community or it doesn't. And what Lincoln is talking about there is one nation, under all, under God, whatever you want to say, if you'd like to believe that, but one nation. And the notion that I think we're grappling with as a country over health insurance is really about, do we really think everyone should have a right to sit at our health care table of plenty or not? Now, it is certainly true, as Owen said, no American likes to think about people dying when we could treat them in relatively, I would say, normal ways. We don't like to think about that, and that's why we require hospitals to stabilize patients. That's what INTALA is all about. Note, we don't require hospitals to treat your cancer and actually operate on the tumor. We just require hospitals to stop the bleeding and to stabilize the patient and send them home with a couple of days' worth of painkillers. That's the requirement. Then hospitals do go on with their various missions and various cross-subsidies in phenomenally Byzantine ways to do lots of care that ends up being uncompensated, which really means shifted to the rest of us. So I really think it does come back to, do you want a community in which everyone is included or not? A number of issues make this complicated. It's going to cost a lot of money. It's true that some people are here illegally, and it's also true we have roughly 47 million out there who don't have anything now. So, you know, there's no question a lot of change has to happen. What I'm heartened by is the sort of range of people across the country. If you start in Massachusetts, where I think you have to, they were the beacon. It was there a Republican governor aspiring to the presidency, used the word all, and a legislature that is arguably the bluest in the country, except for California, was willing to accept the word limit. And those two things, my friend, are the basis of real compromise. And that was catalytic. It inspired a lot of people, including the governor of California, very different place, twice as many uninsured as a percentage of the population as in Massachusetts, no uncompensated care pool. And not to be flip about it, but you could put the illegal, undocumented aliens in Massachusetts in my car compared to California. So it really is a very different problem he faced, yet he proposed trying to do something that is in many ways, in sort of a wonk land, first cousin of Massachusetts. Look at the Democratic candidates, pretty much except for Kucinich, with all due respect to the single-payer dream, all the others are pretty much a first cousin of Massachusetts, a little bit different, a little bit there. And on the Republican side, I would say pay attention to Senator McCain's plan, which actually looks very creatively at, I would say, much smarter ways to subsidize people in the individual market. Now, they're running for the primary in South Carolina, which you might have heard is not France, so they're not going to embrace mandates. But they are talking about serious public expansion, serious coverage expansion, and, back to Corey's point, getting cost growth control under, if we don't do that, I think we all know that we're not going to be able to afford health insurance as a country. So I don't think we're on the verge of a civil war, my friend, but I think we're on the verge of a serious conversation about how to make this one community. On that little preachy note, maybe I should let you guys go have lunch. Join me, though, in thanking this amazing panel. And as you leave, if you would leave your cards with the guys out on the desk, that would be really helpful if you're interested in finding out more about chat. Thank you.